Thank you. We can go ahead and get started while we're waiting on Dr. Frank. Commissioner Britton will not be able to join us this afternoon, so it will be just us, and we're expecting Dr. Frank also. I guess I'm going to formally call to order, welcome everybody, and a reminder to silence all your mobile devices. Since I'm not officially a member or a committee member, do I do the motion to approve the minutes, or did one of you guys do that? I'm looking at you because I feel like you have the most knowledge about this.
I've run a meeting, I said before. If it's okay with the group, we can ask somebody to take over today.
Okay.
One of the members. So,
Okay.
Sheriff, you ready? It's up to you, John. All right, we'll call the meeting in order. We need an approval of the agenda, so if somebody will make a motion for that.
I'll make the motion.
Okay, do we have a second? Motion is approved on the agenda. Approval of the last minutes of the meeting. If there's not any changes or additions or deletions, we'll have a motion to approve the agenda.
I'll make that motion.
Have a motion second? We have a motion and a second. That motion does pass. Okay, presentations today. We're going to recognize Dr. Katie Samuels to introduce the branding and the team. Katie?
Thank you. And let me just write down this note here. So I do want to make a comment about the minutes in our last agenda. We had made some recommendations to move forward with some strategies. We are still working through some of that to create budget proposals that are connected to objectives for the strategies we were looking at. So, and I'll talk a little bit more about the provider proposals at the end of this, but what we're hoping to do in January is to bring you back some budget recommendations and strategies for our internal peers partnering for excellence, as well as the 3 provider proposals that we've been reviewing since the request for proposals was released. And I'll go into more detail about that towards the end of the presentation. But really what I wanted to spend the majority of our time today talking about is the launch of our port team, that we're really excited about getting that up and started and bringing some people onto the team that I'm super excited about and really excited to introduce you to, and talk about some of the data collection that we're setting up. So feel free to ask questions or ask us to pause at any point as we're going through the port information, because it will be pretty rich with what we're doing, what we want to do, and we want to also infuse that with the vision that you all have for the program. So, introducing our port team branding. We got the idea for this to create a brand identity for the port team, because it's not only encompassing post-overdose response, but the culture that we're creating around this response is really driven through social determinants of health and how we can support people. When we did the analysis of 12,000 911 calls, we saw the number 1 call was falls. So how can we as a port team or a response team be able to go in and assist, but also look around at those social determinants of health and see, does this person have a substance use issue going on? Is there a food insecurity? Is there some other root causes that's impacting the high number of calls that we're seeing? And the falls was just an example of that, but there were a number of other repeat calls that could have a root cause that's based in some substance use or other social determinants of health that our BEAR team here will be able to approach in a way that a traditional EMS response wouldn't. So we really want to leverage that and create this culture of we're going to show up where we're needed. So the BEAR, this is Brandy's idea here and vision, because I remember when she first started working with me, and I'd worked with the county for a little bit already, we were looking at the county and she's like, I can find it. It looks like a bear with its mouth open. So when we were looking at what to call our team, we were like, let's call it the BEAR team. So Burke Emergency Addiction Response, and we are officially the BEAR team. So did you guys see the bear before before that, can you unsee it now? What do you think? So we were looking at some of the symbolism behind the bear, that it's strong, it can be seen as a protector. We also do have some black bears around here, you know, so we felt like it was a good, a strong identifier for the Burke County team. So I'd like to introduce you to the team, and if you guys want, you can come up here to our table, like all four of y'all, come up here, yeah. So we have Miss Mary Jo Silver, who was formerly with Olive Branch and has experience already being a co-responder for our current community paramedic. And Tina, you can come up here too. Y'all just sit down. Sit down.
I didn't know.
So, you know, when I'm obviously not standing up and doing a full-on presentation, so I'm going to make you guys.
Okay.
But Mary Jo worked with Tina for the past year and a half as a co-responder. So she's very familiar with the area and the people and the needs of the community and has strong connections with our providers. So we're super happy to have her on. We have Miss Lee Gant, who we stole away from Partners. So, and Lee has worked with Burke Recovery before. Her and Brittany have a long history of working together. Also is a resident of Burke County, knows the county very well, knows the players, the people, the problems, all of it, and has hit the ground running. We have Matt Hare, who comes to us from Burke Recovery, and he was the director of the Flynn Home and worked with those gentlemen out there. And I know that he was very passionate about the work he was doing there. And I know that it had to be a personal call to him to be able to leave that and come work for us. But we're so lucky to have him and hit the fire that he's bringing to like saving some lives. And then Tina is our community paramedic, and she will be joined by a team of 3 other community paramedics to hopefully get this up and going and fully launched by January 1st. So do you guys want to say anything? I'm not putting, you don't have to, but if you'd like to.
I'm just glad to have this opportunity.
Yeah. I'm excited to be back in Burke doing this. I stepped away for a brief moment and realized, nope, I'm supposed to be back here, so we're going to do great things. We've got a lot of good knowledge between us, so and work well together already.
Yeah, I'm excited about the team that we're forming. There's a lot of good personalities, and we all seem to be put pretty good. And most importantly, we're going to save lives. And for somebody like me that comes from addiction and comes from a place where I didn't think this existed, and I know it exists, I want to be able to tell people like, hey, it's not a fairy tale. Like, there is help out there, and I can show you where to go. And so I'm really excited about that.
I'm just excited to have help and to be able to get this thing going. And we have another incoming community paramedic back here too. Crystal.
We've actually extended 2 offers, and both have accepted. So we'll have 3 paramedics to start the process. We'll be looking for a 4th, which is still posted.
Maybe we just need to make a giant circle around the room with the chairs. Because I think it is a nice point to illustrate that all the people in the room, like from different agencies, all working together to make this happen. And it has been really interesting for James and I to get to work so closely together and to get these 2 departments that are really in line and working toward a common goal, and that's to build this core team. So it's been a nice partnership. And so, like James mentioned, we have some open positions. We have 2 PM shift co-responder positions that are open. We've gotten a couple applications in, but haven't scheduled any interviews. So we really want to get those positions hired by January 1st so that we can get our 24/7 coverage up and going. So if you guys know of any peer support specialists that might be interested in working that PM shift, it's a 12-hour shift in a schedule that I could never memorize.
A swing shift. Yeah.
From us, I just had a peer training and, Brady,
One,
that's
yeah,
right.
from at least one, two, actually.
Yeah.
Two. So we have 5 total who have applied now. We were waiting forever for folks to apply for that third shift position, because if you're familiar with addiction at all, a third shift position could be a trigger possibly for someone who is used to staying up all night, maybe doing things that they shouldn't be doing. So it's questionable as to how healthy that could be for somebody. But somebody who is secure in their recovery, maybe has some extended time in their recovery, or maybe who is just a night out, or insomniac, that might be just right for them. So it has taken a little while for us to get some folks to apply for it. But as of today, I do have 5 people who have applied for that position. So we will soon start that interviewing process and hopefully find the right person. So it's exciting.
Yep.
It's this chair.
Oh, it's the chair. I thought you were so next, I want to invite Zach to come up and talk to you all a little bit about the dashboard that he's created through ESO, and he's been really great at helping us set up some metrics that we want to start tracking on, and also have a baseline. So as we're looking at these numbers today, this could be what you consider a baseline, where we're measuring like from the time that we get our team up and going, and that's our intervention, like the improvements that we can make over time in some of these metrics. So thank you so much. And I don't know, do you need the clicker or no?
John's got to step
Oh, you
back.
gotta.
Scroll through.
Yeah, absolutely. You can sit wherever you want.
So a quick introduction to ESO. ESO is basically our electronic healthcare record reporting system. It's basically where we take all our incidences, where we have patient encounters, and have the ability to report and be able to track those incidences. With that, it also allows us to do state reporting as well. We're fall under the branch of NCO EMS, so all our state repository data is directly reported to them. So we have to have a QA process. So Katie came to me saying, how can we bridge some of this gap from what we're seeing from a 911 aspect and start bridging that into what it looks like to our MIH program, what it looks for opioid response, and how can we kind of start tracking some of that data and start merging some of that together. Up at the top, I'm not going to go all the way up to the top because we have some patient demographics in it. So we're not going to go all the way to the top, but it shows, for patient care incidences through the last 360 days, EMS ended up having, it was like 20,600 some calls that we ended up responding to for patient care incidences. We had several incidences outside of that, whether that could be for standbys, for training operations, and other stuff that are generated as a secondary report, but that's all from patient encounters. What I'm able to do on the section above this is able to break that apart to the individual patients and how many times EMS has been called out to that individual, and able to track that. So we can relate it back to those incidences and have a tracking record, look through outcomes of why that patient was seen, and kind of grow in their healthcare and kind of STEM plans with our community paramedic team and our peer support specialist to go out and maybe see if this is a safety issue, if something's going on, or if I have frequent overdoses, can we get these individuals to the help that they need and start building some of the resources that can kind of be a benefit to those individuals. As you see, one of our kind of secondary tabs that come up is going to be our overdose incident report. So this is incidences where our EMS crews have responded to an overdose of some sort, and basically the patient has responded to them and said, I've overdosed on such, after receiving Narcan, getting them to the point that they have to be to where they can get them to have that verbal communication. So over on the side, you've got kind of unspecified data, and then it gets kind of carries down in different categories of the different types of opioids that may be at use. John, if you want to scroll down.
What's unspecified data going to tell you?
Do what?
What is the unspecified data going to tell you?
So that's going to tell you that this was an overdose-related incident where these patients have overdosed, they've been given Narcan, have gotten them to the point to where we've restored their respiratory status to get them back to breathing and being able to transport these patients to the hospital.
They just don't tell you what, you don't know what the substance
You
is.
just won't know what the direct substance they took until the hospital does lab work to be able to kind of figure out
Do you
what.
move them back into another category after you determine?
We do not, because this patient care report is locked. So what the hospital does on their side, we don't see that until after the overall healthcare report is complete.
Does it show anything if they refuse to go?
So that's kind of going into the secondary category. And this is right now directly derived off the 911 response. So you can see some of the canceled, no patient contacts. A lot of that data is being captured through our medical alarms, some of our public assist, where we're going out to where these people are not true medically, do not require medical need per se, but their living status could be questionable, which could spear some of the kind of life safety questions for that individual that our community paramedics and peer supports can go out and evaluate to make sure we're not having to offer some type of resource for that patient. Some of the data also includes some patients that we've went out and treated, some kind of long-term health crisis patients such as diabetics, CHF, some infection control, that we're able to pull that data and be able to see how these people aren't necessarily needing to go to the hospital, but they are needing some type of help, to whether it's diabetic management, going out and having us give them basically sugar to be able to sustain their diabetes to get them to a stable point. Yes.
Okay,
yes.
before you go any further, let me remind our group, if we ask a question and I'm guilty of it too, press this red button, because this is being, a lot of people are watching this also. Another thing I want us to do, there are a lot of acronyms that a lot of people don't understand. So if you think it's one people might know, let's call out the acronym one time so people will know what it is, okay?
Sure, absolutely.
All right. Thank you.
So we try to capture after that into some type of community paramedic responses, some patient care reports that Tina has been completed for our community paramedic side. So Tina's been able to successfully treat and respond to 255 individuals in our community and provide them assistance. And then once it drops below that, our crews, once they go out to these calls, we have a MIH referral tab for the mobile integrated health referrals. And this actually builds out some of the classifications and categories for what these referrals are coming in as. So hopefully in combination of this data right here will give us a great starting point to start really taking this program off, because for just the MIH referrals alone, you can see it's going to be quite a substantial process just getting this off that could really impact some of our community members that may not fit into a category of needing a hospital, but they just need the resources to kind of get them through. Any questions on any of this?
What is health supportive services?
That's just a generic term. It's just where they're requiring some type of health support service. Ultimately, it's a case-by-case basis. So whenever the crew responds to that, they type a narrative per se to that individual. So we'll be able to go in and pull that patient care report to that direct individual and be able to review that data to say, this is a type of support services they are needing. And then that will allow the community paramedic and peer support to decide, we've got this available resources that we can provide to this. And it gives them a little bit of ability to pre-plan prior to going to that incident or trying to make a phone call update with that patient to make sure that's a request that they are wanting to have. So it kind of gives you that kind of bandwidth before you actually send our individuals out to investigate, to say, Is this something that's going to be a long-term care situation that we're going to have to provide this support? Or are we going to have to actually provide these resources to get these guys into whatever type of care they may need?
So I do have a question. I'll push the button and make that. So I can't see those golf posts. Is there anything specific y'all can say during y'all do with people that are unsheltered or unhoused? Is
So,
that category up there?
so a lot of that, it turns into kind of the resource management.
Right.
So, you know, they'll come in, evaluate whatever that need may be, and then maybe have like, I don't know, adult services step in as a resource and say, hey, this patient's living situations is here. How can we better benefit this patient or get them into the type of care that they need?
Dr. Woodward?
I noticed, and it's not unsurprising, that about 40% of people either cancel or you can't make contact. Do you all have any information on Good Samaritan law or materials on what you're doing that you're able to leave with them or try to decrease
So I
the fear?
think the cancel call is a kind of misconception there, because those aren't for this related tab field that is pulled. These are incidences that are not necessarily canceled calls. They're canceled for not a medical need. So this may be like situations for a medical alarm or situations to where an individual has fallen, but they're not injured. Just, you know, a husband and wife, and the wife is unable to lift her husband up out of the ground, but he's not injured. So whenever we go in and collect and document these calls, it gets documented as like a non-medical necessity care. And then once that turns over, we still complete an incident tab and we still submit a form that goes along with those charts that captures, you know, was it a medical alarm? Was it a fall assist? And then that kind of breaks that category into a more kind of separate subcategory, if that answers your question.
Okay, you're gathering a lot of data. Who are you going to share the data with? Is the sheriff going to know this?
So, I mean, this data right now is basically captured to be able to benefit what the need for the community team is to get them started. You know, of course, the sheriff, if, you know, under request, can have any of this information that per se he needs. And then, of course, once we kind of get this program up and running, I'll be sharing this data with Katie and being able to get that to be shareable, to be able to capture that once we get identified of the markers that we want to see and report for this program. This was just kind of the initial, to see where the initial need was.
And what do you think the timeframe's going to be where you feel comfortable with the data that you're receiving?
So, of course, with the team kind of getting up and started and getting them going, it's going to take some time to start building some of this data, because then you're going to get a kind of, I guess, a misconception of the data, because the numbers are going to be so relatively small in the initial phases, and then you can build them out probably quarterly to see updates.
I also think there's going to be two sets, there'll have to be, right? Two different data sets that'll be available for sharing. This particular set, which has a lot of HPI in it, cannot be shared publicly. It would have to be an internal document with those that have HPI privileging. Okay. And then there'll be a secondary document once we truly get those fields worked out that will have the ability to share, that will not have the HPI healthcare protected information that will be attached to it so that it can be generated for public consumption.
That's probably a better way to say it, but yeah, that's what I said in a nutshell.
Any other questions? Zach, you can move on.
In my mind, what I would like to see happen is that we have some indicators that we built into our contract or our proposal for the port team. So I would like to have a dashboard built with those metrics in it that I will be able to share with you guys monthly, so that we can track on if we're reaching our performance goals. So I think it's really fascinating, and looking at when Zach was showing me the dashboard, I was getting really excited because I could see the potential impact that this team can have in the community, and to help build capacity for EMS so that the emergency calls are getting the emergency response, and the calls where we have more of a social determinant need are getting the right resources also. And Johnny, I can move into the next thing on the agenda.
A quick question about the port team. Are there plans to, or is it already within their toolkit to be able to offer medication-assisted treatment, point of care in the field?
Do you want to come up here?
Yes, so to provide a little follow-up on the MAT side of things, so obviously in the state of North Carolina, we have to go through all of our protocols, and they all have to be approved at the state level by the Office of EMS for us to be able to initiate, maintain, and continue and control those. Part of that is that documentation that has to be done. Our current medical direction, which is Dr. Frank, who's not here with us today, has to sign off on our protocols to be able to administer that medication as well as to sustain that long term. So we have that protocol that's been written. That protocol is with him. He has approved. We are now in the process of getting that to the state of North Carolina. The state of North Carolina will then review it and make sure that it's in alignment with what Dr. Winslow wants us to be able to administer and adhere to from a treatment plan. Then we'll get the thumbs up from that when it comes back. So we're actively in the process. We're just not all the way at the end of that process yet. So once we get there, which I'm anticipating is probably because of the holiday, will be in the very beginning of the December timeframe. Then we'll get medications on order and get all that process started so that they'll be here. There'll be an education period, so we should be online with our January start date without any significant problems.
That's really exciting.
Yep.
Is that baked into the funding that has already been put in place for the port team? And I'm assuming that that's sublingual products and not long-acting injectables at this point due to cost.
Correct.
Fantastic.
And we are looking to add on Dr. Meek as an assistant medical director to build capacity for Dr. Frank and also have that specific expertise on board as we're starting up the program. So we're looking to potentially add that into our strategy in December.
One of the things from emergency services which is beneficial for us is we have a primary medical director, Dr. Frank. We currently have an assistant medical director that deals with our trauma services side as well as a lot of our oral boarding and things of that nature because of what Dr. Frank's role in the entire community is. He can tend to be a very busy individual. So having those assistant medical directors, with those specific skill sets is extremely beneficial. And it's also a really fast touch point for us to be able to make a phone call 1 o'clock in the morning and say, hey, we've run into this problem. What would you like us to do? And Dr. Meek has been very amicable to that and is excited about having that opportunity.
The information that we gain from this, other counties around the state are doing something similar, is that correct?
Correct.
So we will be able to develop strategies along with other counties, is that correct? Okay.
So we're already communicating a lot with our surrounding counties. From the really unique part about this entire situation is there's no guidebook. There's nobody in the state of North Carolina across all 100 counties, across all of the programs that are currently running that is exactly the same. Nobody is doing that. So it's really build it to meet what your individual needs are. And through our communication with Caldwell, McDowell, Buncombe, all of our area providers and what they're doing. And I've actually got great friends in Union County, we're communicating back and forth. And I talk to him frequently to say, he's like, well, where are you guys at now? What are you trying now? And they're trying to mirror some things that match with us. The important thing for us, I think, is recognizing the small incremental steps because those actually get you where you're going. It's not those giant leaps that you make to get somewhere. Recognizing the social determinants of health, which are also going to be the mental health side, the frequent falls, the medical alarms that maybe there's alcoholism in the home or whatever other things that are going on, being able to start curbing a lot of those as well and being influencers in the outcomes for those patients is as important as what we're doing on the opioid side, because it's getting us in those communities where we're seeing them very quickly, and it's helping that response. It's really augmenting what that response is. And collecting this data, You'll also see it, there's a secondary that reports over into, it's called biospatial. And we'll actually be able to compare a lot of that information back and forth across what the entire state of North Carolina is doing based on what our data is. So our problem is right now, when you look at the graphs, it looks like, well, we don't have a tremendous amount of data, and it's true because we're in our infancy and we are just now collecting it in the ways that we can grow on. Before, it wasn't completely in captive of what we had the opportunity to collect. And that's the important part, is realizing that we are right at the tip of the spear right now.
Zach, great presentation. Anybody have any more questions? All right, hearing none. Katie, let's move on to the update on the approved strategies.
You can stay if you want. So these are our, the strategies that we funded back in August of this year. So we wanted to take a few minutes to give you an update on where we are with the implementation here. So even since I made this presentation a couple weeks ago, this has been updated because we have our community navigator, Lee, here with us today. She started last week. And then our port team, we've had the 2 positions filled with Mary Jo and Matt, and still looking for the 2 PM positions. We have a nice update on naloxone. We have found a vendor that will give us naloxone at $22 a box, where we were paying $38. So that'll extend our ability to saturate the community with naloxone even more. And our naloxone vending machine, which isn't necessarily part of this, it was funded through our Blue Cross Blue Shield grant, and with support from partners. We've distributed 140 boxes of naloxone in, how long would you say? 2 months?
2 months and 2 weeks. Yeah, 14 weeks, I'm sorry, 14 weeks total.
And Brandy and company are keeping it stocked with lots of different things. So it has naloxone. They put in some cold weather supplies when we had that cold snap, just health products. And so we've had people that are really taking the opportunity to get some things that they might need, especially during the winter time. And so if you have anybody that would like to donate to the naloxone vending machine, I think small-ish items fit in there, and it's got an assortment of sizes, so we can package it up and fit in there if anybody has anything they'd like to donate to it. Our provider-led strategy, so in August we funded Spark, ACA, or a Caring Alternative, and High Country Community Health. So Spark has already been in conversation with Department of Social Services here and are already receiving referrals from DSS. And if you'll recall, this strategy was meant to offer really intensive support to families that are at risk or are already involved in DSS. So they are well on their way to being in full implementation and starting to receive referrals. So they're fully staffed, and 3 of their 5 staff have completed the required training. They're receiving ongoing training in substance use and recovery. 5 new referrals received this month and 1 active case. And there have been a notable increase in referrals and engagement in partnership development. So this is pulled directly from their contract when we were looking at implementation milestones. You can see here that they're meeting their goals. They are still looking at the licensure and readiness, identifying clients. I've got licensure and facility readiness on there twice, so that probably need to fix that. But they are making good progress toward meeting their performance metrics. A Caring Alternative, this is for Substance Abuse Comprehensive Outpatient Treatment, or SACOP, and SAIOP, which is Substance Abuse Intensive Outpatient. Did I say the same thing twice? I did it already right? Okay. So they have submitted documentation for site licensure and awaiting approval. They've also started hiring and completing trainings. They have appointed a program manager and have begun marketing and outreach materials. And all 3 of the providers have drawn down their startup funds. So this was their implementation milestone chart. And they are also making good progress toward their performance goals. The third provider-led strategy is High Country Community Health with low barrier MAT. They're in the process of hiring their clinical pharmacist and nurse practitioner. They're already receiving referrals from community paramedic program. They're actively engaged in the port implementation and planning, and they've also drawn down their startup funds. And this is their chart for implementation milestones. And they were more of an expansion than a new startup, so they already had some momentum going that they're able to build on and start seeing people. And so what we're doing in partnership with them is building out that tracking mechanism so that when we have an intake in with the Bear team, then we can track what happens to them once they're referred out somewhere. So once we're making the referral to High Country, we have that partnership agreement to be able to do some follow-up case management through the Bear team and through our community navigator. So Recovery Court, this is their annual report metrics where they serve 15 people during the year, 100% referral and linkage to treatment, 86% treatment adherence after 6 months, 73% housing retention, and 53% employment, 87% connected to other services, and 60% engaged in harm reduction supports, and all 100% received naloxone kits. And then this takes us into the next section, so I'll pause for questions if you can.
Yeah, let's pause for questions. I have one.
Okay.
The information you're getting from these people, are you getting that, the updates through email, or are we doing site visits to see exactly where do we have enough help to do that?
Yeah, absolutely. So what I've done is I've created standard reporting forms that they submit to me monthly. So we just started that. November was our first month where they're submitting an official report. And I've created the forms to line up with the metrics in their contracts as well as what we have to report to the state for opioid settlement spending. And I'm also meeting with them monthly. So in November and October, I had one-on-one meetings with the providers to check in with them if they needed any help, to make sure they're getting their startup funds drawn down, and to also make sure that they understand the reporting tool, which was a big factor in, like, I wanted them to have some input into how they're reporting, if they understand it, and if they need any help with it. So we met with all of them, and I'll continue to do that. Meet one-to-one with them at least monthly, and then I'd like to also get maybe even a quarterly grantee meeting together where they're all coming together and sharing what they're doing with the opioid settlement programming. And for our next year going into 2026, when we're creating the calendar, part of the terms of their contract is to come and speak to you all directly and give you presentations on what they're doing. So I'd like to see us start doing that probably at our March meeting where we have presentations. We'll have January, March, May, so maybe March and May we have those presentations.
Fantastic. Anybody got any questions for Katie on the strategies? All right, hearing none. Katie, let's move on to treatment center planning.
Okay, awesome. So this has been a topic of planning and conversation for many a year here in Burke County. And we feel like we're getting some momentum and traction around it. And we've had, and Johnny has the historical knowledge about where the funding from the state's coming from. We have a total of about $6.5 million that we're looking to draw down from the state for a treatment center here in Burke County. And so Partners is housing $3.5 million, and we're looking to draw down the other $3 million from the state. So over the last couple of weeks, I've had to submit an additional scope of work about what that might look like so we can get that drawdown. And so what I did is I started with a statement of need, and we had data from 911 telecommunications. We had 6 months of 911 calls. We had some ESO data, and I had behavioral health reports from the hospital and ED for the past year. And so looking at that data and pulling it together to create a statement of need of what kind of facility we might need here in the county. So in all of that, we had over 1,000 behavioral health or substance-related ED encounters in 1 year. And if you guys will recall, up until recently, we've been in the top 10 of counties for ED visits. Behavioral health patients occupied 33,000 bed hours, averaging 39 hours per stay. Overdose visits remain high with 246 in 2023 and 142 in 2024. EMS responded to more than 300 psychiatric calls and 151 overdoses in 6 months. No local stabilization center, and the closest options are over an hour away. So we're looking at Asheville, Lenoir, Gastonia, and Cleveland County for any kind of crisis stabilization, or Catawba County. So with all of that, we started having some conversations with the providers also, and the proposed solution is a facility-based crisis center. And we've talked a lot about, and just in full transparency, my beginning thoughts were a BHUC, or a behavioral health urgent care, where people could come in and be assessed and then connected with resources. So if you think about an urgent care, what it is and what we have, picture that for behavioral health crisis and substance use crisis. But the flip side of that is if you have a person that needs hospitalization or inpatient treatment, the BHUC doesn't offer that. So in talking with the providers, they recommended a facility-based crisis center, which is a 16-bed, 24-hour stabilization center. So the average length of stay here is going to be 5 to 7 days, but that's enough time to get a person stabilized, and then our peer support specialists and our other team members can get them connected to longer-term treatments like TROSA, Black Mountain. So we're actively creating those partnerships and connections to long-term treatment until that's a solution that we can have here in the county as well. It serves adults with mental health, substance use, and co-occurring conditions. And it also features an enhanced intake and triage, which will take the place of that BHUC. So it's a no wrong door policy. If a person's having an emergency, a behavioral health emergency or substance use emergency, they can come here and it will essentially function like a BHUC, where they can be assessed and then referred out if they don't need the inpatient piece of it. It's designed to reduce ED boarding, shorten EMS and law enforcement transport times. And we also identified the need for a first evaluation site, so that when a person has an involuntary commitment order, or IVC, they're required within law to have a first evaluation within so many hours of that. And we don't have that currently with our providers in Burke County. So this could potentially be a first evaluation site, so that when law enforcement is picking up IVCs and taking them, they have an alternate to the emergency department. And let's see, what it offers: medical and psychiatric assessment, withdrawal management under nursing and medical supervision, short-term stabilization and crisis counseling, peer support and recovery navigation, and coordination of discharge and outpatient care. And one of the things that we were running into with the longer-term treatments, a lot of the treatment centers want a person to have gone through a medical detox before they admit them into the treatment centers. So this is a place that a person can go and be medically detoxed to be able to be connected to long-term treatment. And I think this is the last slide about this, so I'll stop there and see if you guys have any questions.
Anybody have any questions for Katie?
No, I think it's amazing. About time.
I do. The treatment centers that are somewhat close to us, for example, TROSA, are they aware that we're trying to do this, and are they going to be? I've getting mixed stories about what TROSA will take and what TROSA won't take, and it's usually TROSA won't take. So do they understand what we're trying to do with this facility, this crisis center, to get somebody ready to go?
Mm-hmm. We talked a little bit about the idea behind a facility-based crisis, and they were happy to partner with us on it. Some of the feedback that we got when we did the site visit is that everybody that comes to visit, there are different counties that are looking at these interventions or opportunities to do something in their counties. They're saying, don't go back and try to create a TROSA, because it's not for everybody. And that's some of what we're finding in the field, where we're connecting with people that need support like TROSA, but it's just not a good fit for them because of their program rules and regulations, which It's very restrictive, yeah. So I think that our takeaway, and you feel free, more than free to speak up about what you think too, but it's just not a fit for everybody. For those that it is, it works well for. But it really does seem like it's a niche population that maybe don't have kids or dependents or are at a place in their life where they can walk away from everything and be a part of that for 2 years. So I don't know if you want to add anything to
Oh, I
that.
agree, and it's a last chance, I'm sorry. And it's a last chance type of place. I mean, it is when you can't do it anywhere else and you can walk away from everything, or you've already lost everything and you can go away for 2 years, because it's like no cell phones, no communication with the outside world, no anything. You have to be very committed to make it for 2 years somewhere like that. So it's not like we ever can bring a TROSA here and develop and build a TROSA here and have something like that here. That's not what we'd want to do. What we want to do is have some time to get folks where they can make a decent decision, and then we can get them somewhere else. Like if we wanted to be able to put them at Flynn Recovery Community, where Matt's coming from, they have to be medically detoxed before they can go there, because there's not a full-time nurse working on staff there who can sit through and observe somebody go through the detox that they need to go through. Like you must be medically observed to go through detox for benzodiazepines or alcohol or something like that. They're not equipped to do that. So this place would provide that medical supervision to get someone through the detoxes, or even if it's something like opioids, you don't have to be medically supervised because you're not going to die from that withdrawal, but boy, you feel like you're going to. So they can help you through those withdrawals with something for your nausea, or maybe a clonidine for your nervous system or something like that, and help you through those withdrawals until you can start making a little bit better decisions. And that gives you time to have some case management until we can get you into a place, because very seldom can you walk up to the door and say, hey, I need to get in here for, treatment right now. It takes a few days to get somebody in, and this would provide us that opportunity to get the person in a better place mentally and physically, and then get them into somewhere where they could get long-term or even short-term treatment if that's what we had to go with, and that's what this would provide.
We had a saying at the association that if you've been to one county in North Carolina, you've been to one county. And it's really different. And I don't want us to be like a TROSA, but it also, with Zach getting the information that we need, I hope we don't lose sight of maybe long-term for Burke County in some time, and maybe regionalize if we can. But I think the scope of what we want to do is just totally different. TROSA's got, I'm glad for them, but their program is not one that I would particularly adhere to. So I hope we don't lose sight of a long-term facility. I think this is fantastic, along with the data that he's gathering, and then these people coming in here to a crisis center. At least we're making an offer and getting a good start. So that's just my comment on that.
And we're hoping that it will create some momentum with building the provider network also, because once we're able to get everything approved from the state with the scope of work, the next step will be to work with partners to recruit a provider that will come in and help us with the design of the facility, and have somebody at the very beginning stages to help us through the process, so that we can be ahead of site licensure and be up and running in 1.5 to 2 year time frame.
Okay, do I have any other questions for Katie on treatment center planning? All right, hearing none. Katie, let's move on to the preview of the January provider proposals.
Okay, so our next meeting is in January, and we had originally discussed hearing from the 3 providers that we had put in this revisit category when we first approved some of these proposals, but we're still working through finalizing the contracts and reviewing that. So we want to bring them back to you all to present what they're proposing in January, and also give you all time to review the contracts that we're drafting before that meeting. So those 3 proposals were from Burke Recovery, who we've met with and talked to Drew, the executive director, and we talked through where the need is, because his original proposal was for intensive outpatient programming, which was funded through a caring alternative. So Burke Recovery has the ability to do comprehensive clinical assessments, or CCAs, and we have a need for that. So they're willing to put that as in their contract as a gap that they can fill in the continuum. For Christ-Centered Recovery Ministries, we've also met with their team and are working on a contract there that's in review for them to provide recovery housing. And so, Johnny, as you're talking about like what the long-term supports look like, we have a huge need for recovery housing and transitional housing and everything past that inpatient stay. So I think we've done a good job of looking at the continuum of from starting with harm reduction in naloxone and then getting people into treatment and engaged through peer support, and then building the provider network so that they have outpatient, and then the next part of the continuum is intensive outpatient, followed by inpatient and crisis services. But then what happens after that? And I feel like that's our next phase of focus, is looking at that part of the continuum of, okay, but now we've got people in treatment, we've got them stabilized. Now, how do we support them in the community and long term? As we're going into 2026 and beyond, I think that's going to be our area of focus, as well as prevention. And then Catawba Valley Health, we have, and I talked to Tim about presenting at this meeting, and then told him that we were going to wait till January. Tim Lentz is the CEO of Catawba Valley Health. And we had talked about reentry, and what he is proposing is actually post-arrest. So we're going back to the contract to modify some language around that and what that looks like. So we'll be sending the drafts of those contracts to you all before the January meeting so that you can have them. And then the providers will come and present to you what they're proposing, and you can ask them questions. And with the contracts, we'll have the legal review and everything done ahead of time, so that if you also decide to recommend moving these proposals forward to the Board of Commission for approval, everything will be ready to go for the February meeting.
I have a question. So the transitional housing, I mean, what number as far as people?
So we're looking at 10, and the contract will be set up almost like a fee for service. So it will be 10 individuals at their cost, like monthly cost, and the total amount of the contract is $120,000. So we just need to share that with them and get their feedback, and if we have to do some negotiating or something. But that's the model that we're looking at, is like specifically for recovery housing per person. We also had tossed around the idea of releasing a request for proposals or a request for applications specifically for recovery housing, because this was the only application that we got to address that strategy.
What about barrier shelters?
I think we would have to figure out a way that would fit within the terms of the opioid settlement, because that was the issue that we ran into with the proposal from BUCM, is that it has to be majority of opioid use or polysubstance use. So it has to line up more with the majority of people being served.
Right. So what you need with them is just more data or information?
Yeah.
Okay.
I know we're not diving into the proposals yet, but one big barrier with recovery housing is capacity to accept people on medication-assisted treatment, and so I would recommend that is a prerequisite to us providing funding to any community-based recovery housing.
Okay. Any other questions for Katie on this topic? All right, we'll move forward to our informal public. Actually, for comments, I'm gonna move around the table and see if anybody at the table has any comments. Or ask Katie if there's anything that you personally need before the next meeting. If you want, go ahead,
I don't have anything.
Jerry, anything? Sheriff?
Yeah, I just want to say, I'm very appreciative of your work, and to have a treatment center here in Burke County is good. I think that we have needed that for a long time, and then just the support and the follow-up after that treatment is important. I think the sheriff's office, we see so many calls where we go out and there's a lack of support when people went to that initial treatment. And of course, I think a lot of their support at home have those same type of issues. So I think just the follow-up after that treatment is awesome. And I just appreciate the work you all are doing with this, and very appreciative of it.
Doc, you have any questions? The one thing, has the media taken any interest into what we've done so far?
Yes, they have.
What, okay, give us an update, what they've asked and what they're looking at.
So we have, do you want to give the update about it?
Yeah, so basically I came to the last meeting, I've talked with Katie and kind of discussed what it looks like hitting the ground going forward. I've talked with Spark to understand what their program looks like, and I'm speaking with Caring Alternative Monday. So, I mean, any connection, any kind of people that would be good to speak to, I'm always open. I think most of you have my card, so feel free to reach out. But I've already been looking at where the rubber meets the road. Of course, we'll cover things like this, but, you know.
You have kept up with what's come out of the North Carolina Association of County Commissioners where the program actually started for what we're doing here with our memorandum of understanding? Okay, good, okay. There's, some people had questions about the monies and don't understand they come from a heck of a lawsuit, you know, that came about, thank goodness. Okay. Any other comments, Katie, on that? All right. So we move on there are no, does anybody out here have any comments? Anybody? Anybody? Okay. So we move on to items for decision. We have none today. And then, Katie, do we have any reports that we need to be aware of?
No, not at this time.
Okay. With that being said, I'll entertain a motion to adjourn. And our next meeting is on what date?
January 20th. And it'll be January 20th, and the Board of Commission meeting is following this one. So we'll have to keep our meeting to an hour and a half, and probably have to use the setup that they're using for the Board of Commission meeting.
That'd be fine. All right, with that said, I'll entertain a motion to adjourn.
I'll make that motion.
All in favor, say aye.
Aye.
That's unanimous, ma'am. Thank you so much for coming today. We appreciate that.